everyone and welcome. It's always, as I said, a pleasure to be in Alberta virtually. We have a chat group at the national level, and I wrote in it that today I'm in Alberta. And I'm pretty sure people were wondering, how can she be there? Is she traveling? But it's the new reality. Virtually, I can be anywhere. Every day, I can be in a new province. So I was so pleased, when I heard about this topic that you were choosing to do today, because it's something that we don't really generally talk about. In the sickle cell community, we talk about all the complications. We talk about, the cure and everything, but reproductive health usually is just left out. And it's such a great honor today to be here and to introduce these two guests who are going to be guest speakers who are going to be talking about it. So in the first part, we're going to have Teonna Woolford, who is going to be sharing her experience and and then in the second part, we're going to have Dr. Nancy Soliman, so that we're going to have now the medical expertise to come and back up what Teonna is going to share with us. So I'm going to introduce Teonna to you. I actually met Teonna in Baltimore, Maryland at the ACDA National Convention. And it was, such a pleasure. And then I feel so, I actually feel blessed and lucky to be able to say that I know these people who are, who have sickle cell and are fighting every day. She was born and raised in Baltimore. She's a very nice, friendly, soft-spoken girl, but make no mistake, the fire is in there. She has sickle cell anemia SS, and she has faced numerous health complications because she's a true fighter, She had like a bilateral hip replacement, a failed bone marrow transplant, and I'm sure she will talk about it. I don't want to read all her bio, I want you to hear it from her. So that's today what I'm going to tell you. Having gone all through that, she's still standing here and fighting. And she's also, most importantly, the founder of a very new and CEO of a very new organization, a non-for-profit organization, the Sickle Cell Reproductive Health Education Directive. So my question to you, Teonna, is tell us your sickle cell story and tell us why you funded this organization. Thank you.
Okay. Well, thank you for that introduction, and thank you guys for having me today. I'm really excited to join you. So before I start my little slide presentation, I'll just share my story because it's going to help segue into why I founded this organization. So I was born, like my bio said, with sickle cell SS. And looking back as a child, I always say that I grew up like relatively healthy, but I was always in and out with pneumonia and acute chest, like basically annually. I just really didn't have a lot of VOCs. And then when I hit puberty, that's when things kind of started spiraling out of control. And I started having frequent pain episodes and avascular necrosis in all my joints. So by the time I was 15, I had my hips replaced a week apart from each other. And, it was like really mentally devastating, missing prom. And I missed like 80% of my junior and senior year. My graduation was on the line, but by the grace of God, I made it with a very high GPA. And I was just always in and out of the hospital. And I've always been like a really ambitious person. And I come from a family of like overachievers. So it was really hard to reconcile wanting to live such a productive life, but my body was like always failing me. So when I graduated high school, my team of hematologists, they approached me about doing a bone marrow transplant. So I got on the Be the Match registry, and like so many, I didn't have a perfect match. And that's why I'm such an advocate of like African Americans becoming donors. But so I kind of let go of that. And then I started hearing about a clinical trial that was being done at NIH, the National Institute of Health, and also at Johns Hopkins, which is pretty close to me. where they were doing these haplo transplants. So my mother was my donor, and I was pretty desperate and depressed at the time. I just felt so defeated. So I was basically willing to do anything if it meant that I would be cured from sickle cell. And I wasn't even really considering a lot of the risks. The only thing that I was really concerned about was the potential risk of infertility. And so I shared that during my informed consent process, and my concern was dismissed. And I was told that I shouldn't even be worried about being infertile from the transplant process, because with all my complications from sickle cell, I was probably already infertile. And it's one thing to hear that at age 19, but 10 years later, at age 29, you know, it has really devastating implications. So anyway, I've decided to go through with it. You know, I had the chemo and the total body radiation, and it was a really tough process physically, but way more difficult mentally for not just myself, but also my family. And then about 3 months after the transplant, I spiked a really high fever, and it just wouldn't break for like 2 weeks straight. And then when the fever broke, my blood count started plummeting. And what we learned was that rather than my bone marrow revving back up, it just shut completely down. So I wasn't really producing white cells, platelets. It was a really vulnerable time because I was at risk for like hemorrhaging and all kinds of infections. And I was in the hospital going through that for 4 months straight. And then like halfway in that 4 months, we found out that I rejected the transplant, which it was just shocking to me, because of course they tell you that you could reject, but when you're so desperate for a cure, you just think that you're going to be one of the ones in the majority who's cured, and it just didn't work out for me. So then fast forward to last year, my hematologist, she actually studies fertility and sickle cell, and she had tested some of my hormone levels, and she called me like middle of the day, and she was like, I don't know if you want children or not, but if you do, we have to have serious conversations about fertility preservation. So I did some research because I was looking for resources, because the cost of that is like $10,000 and insurance does not cover it. And when I started Googling, what I found was there are so many grants available for egg freezing, but you have to have a diagnosis of cancer. I was able to find one grant for women of color, but they rejected me because of how low my hormone levels were. So I got to thinking that like people like me and in the sickle cell community who go through these curative therapies just deserve so much better. So I had this vision to start my own foundation where I would give away grants. And my hematologist, she's like, that's a big vision, and we probably need to also work on advocacy and getting insurance to cover the cost of egg freezing and sperm banking. And then I started reaching out to another one of my mentors who's been working in women's health and reproductive health for a very long time. And that's when she started telling me that there's so much more than just fertility. Like, we don't even think about delayed puberty, delayed growth, priapism, contraception, menopause, hormones. So that's how it kind of grew into a much larger organization. We're very, very new. I have not even launched my website yet. I'm launching it on June the 19th. So that's my story and a little bit of background about why I'm doing what I'm doing. And I prepared like a super brief PowerPoint just to tell you guys a little bit more about my organization.
Wow. Thank you so much, Teonna, and we are excited to hear about your organization. And before you do, I just want to mark and say that this is an important, this is a serious issue that we have to consider all the time, because even the treatment of hydroxyurea on the long term can affect. So, and when we ask the physician, do you really check that before you put those young people on hydroxyurea at a very young age? The response is really no. But I understand also, you have to make a decision between keeping them healthy and alive or looking at their reproduction, potential for the future. But we need to take care of that. Thank you, and go ahead. Thank you.
Yeah, and just following up, it's so interesting that you brought that point up because, it is listed as a side effect that hydroxyurea can impact with sperm count, but there really has not been a lot of research in what it can do to ovarian reserve. And one of my co-founders, who I'm about to introduce you to, just released a paper on that a couple of years ago. So that'll be on our website. But anyway, and I'm just like, full disclosure, I'm not really good at making slides, but so our formal name is the Sickle Cell Reproductive Health Education Directive. And you guys see my logo. It's just the implication that we deserve families, even though it's about more than fertility. I really like the logo, and it's such a long name, so we call it SC Red for short. And next slide. So one of the things that I'm super proud of is who we've been able to bring to the table. I've never really seen a lot of organizations where patients and doctors are working together. So both of my co-founders are like these world-renowned hematologists. I have Dr. Kim Smith-Whitley. She's my co-founder and chief medical officer. And then Dr. Lydia Pecker, who is the hematologist that I was referring to earlier. She is my vice chief medical officer and co-founder. And you'll also see on our website that we have a board with a mix of like sickle cell patients and caregivers and advocates and industry representatives and even other C.E.O leaders, because that's how much people believe in this work. And we've been able to really stress the sense of urgency. So that's exciting, just the level of collaboration that we've already seen. So this is my mission statement. Our mission is to advocate for high quality reproductive health care for individuals living with sickle cell disease of all types. We will provide education on reproductive health concerns, establish standards for effective and high quality care for policies and processes that will improve access to comprehensive reproductive health and family planning. So there's just my formal mission statement, basically just stating everything that I already said. Next slide. And these are like our directives / services that we'll be offering. One is, it starts with awareness, because like Viva was saying, a lot of times we talk about like the pain and organ damage and now the cure, but reproductive health like doesn't get a nod. And even for me, like starting this, I was telling you, when it came to reproductive health, I was only really thinking about fertility. I didn't even think about the fact that I did experience delayed puberty, and nobody really even explained that to me. It didn't come up in my doctor's visits, but I did know that it was like incredibly isolating being in that locker room. And so we also need to be aware of like the mental toll that can take, and the isolation with this disease can start really early because of delayed puberty or delayed growth. So we also will be providing education, not just to the patients, but to the providers, because I don't know that a lot of providers are even equipped to start having these conversations, because reproductive health has been so far off the radar for so long. And then advocacy. So we've already taken steps to work on legislation to get insurance to cover fertility preservation. We just feel like anyone who's going to be offered chemotherapy should be offered fertility preservation. And there are already laws in place for like cancer and other rare diseases, but nothing for sickle cell. And I'm excited to have my two co-founders, and we have a medical advisory committee who will be doing research, because there's a lot of data gaps and it's really overwhelming, like how much we don't know. And a lot of what's out there is outdated. And that's one thing that I'm very proud of with Dr. Lydia Pecker, is that she works overtime. Like every month there's a new publication from her, and she's really trying to get this work into the literature. And we'll be offering support. I'm working on a fertility preservation grant, and I'll also be launching support groups so that warriors can have open spaces to talk about things that we've traditionally been too ashamed to talk about, such as priapism or pain with sex. So next slide. These are our values. We have empowerment, because I really do want to empower this community to start having these conversations and to feel comfortable. Like if your doctor's not bringing up reproductive health, they should be bringing it up. And we want to raise the bar to where reproductive health care is just standard of care. Inclusivity is really important to us. Like, we are very patient-centered, so it doesn't matter what your race is, your sexual orientation, like reproductive health touches everyone, and we want to be a resource for anyone who wants this type of support. Engagement, so just checking in regularly with the community, making sure that we're supporting them. And then informed decision making is important. Like, we want to get away. I feel like reproductive health doesn't come up, and then when it does, it's like a hand on the door conversation. Like your doctor's getting ready to leave and you're like, oh, by the way. So we don't want that. And like with this community, it seems like the older you get, there becomes a greater disconnect and divide between providers and patients. And so what I've noticed is that adults living with sickle cell, like they're very close knit. And I don't know about you guys, but on social media in the groups, I see people all the time talking about how they have pain with sex, or how they're too embarrassed to talk to their partner about priapism. And they're really having these conversations with each other and not having them with their providers. So we want to get away from that. Innovation, because obviously what we're doing really hasn't been done before. And then accessibility and equity, those are important too. Just making sure that we actually have support in place for warriors like cancer patients. Next slide. Oh, that was the last one. But thank you guys for listening to me.
Thank you very much. Very inspiring, and also it brings hope, like for you, after everything you've been through, to still sit here and think about others and bringing all these programs that are so needed. Like in Canada, we look forward, and I'm so glad that the Sickle Cell Foundation of Alberta brought you here before you even launch your website. And again, as you all know, as I told you, this is a very inspiring story, but most importantly, you're going to change lives, because so many things are being dismissed, so many things are not being taken care of, and there is no research. So we have to come and do this ourselves, so that, we bring our issues forward so that they're being taken care of. And when you're talking about, in your last slide, you talk about accessibility and equity, just like cancer patients. I have, it brought something to my mind. This morning, I was talking to a mom who is in Quebec in a city called Sherbrooke, and she has 2 young boys with sickle cell disease. And she said that she took one of them to the emergency, to the ER, because he was having a crisis. And she just left the house. When a crisis happened, you don't have time to grab a snack and grab a lot of things. So she said that, well, it was taking longer than, as usual at the ER. And she was sitting there, and there was this small fridge there for kids, and her son wanted a snack. So she told him to go, to be polite, to go tell the nurse, ask, and then he can go get one juice, because she didn't have anything with her. And then the nurse said, no, that this was for cancer, for kids with cancer. And as a mom today, I cried.
Yeah.
And I'm like, it's not okay. It's just not okay. And it tells you how much work needs to be done when it comes to sickle cell. When even a child in an ER room is denied the right to have a snack, you know, when you went through this procedure and they couldn't tell you exactly that you have, this is what you have to do if you want to have kids in the future. And now you come at age 29, you know, and then you are looking for ways to have a family like everybody else. It's not right. Things have to be changed. But I am very also happy and I have so much hope again when I see the physician, those who can bring the solution, sitting with us and working with us. It makes, you know, me think that we are going to overcome this. So it's, again, I'm going to introduce the next guest. What I will say, I know that there are some questions in the chat, but I want everybody to present and we can have a discussion after. It's better if everybody agrees, right? So I'm going to present now Dr. Nancy Soliman. Dr. Soliman, just so you know, you are, I just met you like through this organization and you are my new favorite person. And I'm going to tell you why. So Dr. Soliman is originally from Toronto. She completed medical school at the University of Western Ontario in 2008, completed residency in obstetric and gynecology at University of Calgary in 2013, and her fellowship in maternal-fetal medicine in 2015. Since then, she has been practicing maternal-fetal medicine specialist in Calgary and provide obstetrical care at the Foothill Hospital. Her interests include diagnosis and assessment of fetal growth restriction, as well as maternal hematological diseases, including sickle cell disease and lupus in pregnancy. I told you she's my next favorite person in the world. So when sickle cell is included in any type of research, it means change for our community. It means better care, you know, it means quality of life, and this is good news. So Dr. Soliman and her family love to travel and explore cultures, but during the past years, you know, has understandably, they have been exploring neighborhood backyards on their bikes and skiing as much as possible. Thank God you are in Canada so you can ski when it's winter.
Exactly. It's been
So
a lifesaver.
welcome, Dr. Soliman. So we're going to do your presentation and we're going to have a discussion at the end with everybody. Prepare your questions. You can write them in the chat for me. Thank you.
Okay, perfect. Thank you for that introduction. So yes, I'm one of the maternal fetal medicine specialists. So that means that I take care of high-risk pregnancies in pregnant women. I don't assist women to conceive or assist women with fertility issues, but I do spend a lot of time talking to women before they get pregnant who have various medical disorders or various other obstetrical problems. So I do talk to them quite a bit in terms of planning for their pregnancy. So I got involved with this probably 3-4 years ago when two of our hematologists approached us and said, you know, is there a way that we can try to formalize our approach and kind of have a protocol for how we approach pregnant women with sickle cell disease and sickle cell anemia. So we sort of sat down, we went through the literature. A lot of what we based our recommendations and our local practice on was actually based out of the UK, because the UK has a lot of has a really good document out there about how to approach pregnancy in women with sickle cell disease. So we've put together a local document that we use, and this has allowed us to sort of streamline our patients between our clinic and the hematologist, so that we're always talking back and forth and communicating for pregnant patients, especially as they come closer to their delivery time, and trying to optimize their outcomes. So next slide, please. So what I always tell women with sickle cell disease, and really women with any other medical condition, or really any woman who's had a rough time in a prior pregnancy, is the most important thing you can do is to optimize everything as much as possible before you get pregnant. So if women are wanting to get pregnant, then really in that year or two before they conceive, that's when we should be doing the work to try to make that, to optimize that pregnancy and give her and her baby the best outcome. Next slide, please. So the big thing is to make sure that you have a good team of doctors in your corner, kind of making sure that you're optimized. We have in Calgary, we have a group of doctors that work out of a clinic called the Rare Blood and Bleeding Disorders Clinic that take care of most of our sickle cell disease patients, and making sure that you're having regular annual follow-up with them. It's also, as I said, we and many obstetricians in the city provide a pre-pregnancy consult where we will happily see women, and thanks to COVID now it's over the phone, so you don't even have to travel to come see us. And I think that's probably going to be something that stays forever. But we will sit down with you, go through your history, and talk about specific things that we can optimize in your case and what a pregnancy will look like for you, what to expect, what kind of extra investigations and visits you might need. The other thing that I always make sure, if I have the luxury of meeting with women ahead of time, I always make sure that their eyes are healthy, that they've had somebody look at their eyes recently, that they've had somebody do an ultrasound of their heart recently, that somebody has checked on their liver and their kidney function to make sure all of that's normal. That we make sure, especially in sickle cell disease women who have had multiple transfusions in the past, you can develop antibodies from those transfusions. And those antibodies can have implications for your baby and can cause anemia in your baby during pregnancy. So we want to make sure that we know if those antibodies are present and how many there are. And we want to make sure that all women with sickle cell disease are on high-dose folic acid and on a prenatal vitamin. And as I tell all my women who are thinking of conceiving, a prenatal vitamin, you can take it for years and years. Even if you're not going to conceive for another couple of years, start taking it and start taking the folic acid, because that'll be good for you in the pregnancy. And then finally, we also want to know, has the partner been tested? Do we know the carrier status of the partner? What then are the chances that this baby is going to be affected with sickle cell anemia? And how would the couple want to proceed if this baby were affected? So next slide, please. So the next little bit is going to be a kind of trimester by trimester breakdown of what kind of things we do differently in a pregnancy for women with sickle cell anemia compared to women who aren't affected by sickle cell disease. So next slide. So the first trimester is always a busy time for all women in pregnancy, no matter what. And that's because we're doing dating ultrasounds. We're trying to figure out how many weeks, when's the due date. We're doing genetic screening to see is the baby affected by some common genetic conditions. We're doing routine blood work, and women who have been pregnant before will tell you it feels like they're taking half their blood when they draw their blood from that first trimester, because they're doing blood typing, antibody, we're doing infection screening, we're doing pap smears. So we're doing all of that for all pregnancies. So it is a busy time that first trimester. With women with sickle cell disease, though, there's a little extra. And part of that depends on whether or not you've had really good follow-up leading up to the pregnancy, and if we've had the ability to sit down and chat prior to that, or are we meeting you for the first time and we're sort of trying to get a baseline of where everything is. So I always tell my women with, if I have a chance to have a consult with them ahead of time, I say, you know what, you don't necessarily need to be followed up by my clinic, but you should be followed up by an obstetrician. You're not considered a low risk pregnancy, so an obstetrician should be involved. Again, make sure that their eyes are good, make sure that their hearts are good. Adding to all the other blood work they're going to have, and I usually try to send them for one poke, but adding to that liver, kidney function, a urine culture, and we actually send women monthly for urine cultures because women with sickle cell anemia are at higher risk of growing bacteria in their blood or in their urine and not recognizing it, and that can put you at risk of preterm labor. So that's why we do that monthly. We usually also ask them to, again, if their partner is a carrier, if they want any genetic counseling. Start them on aspirin, because women with sickle cell disease are at risk of preeclampsia, which is high blood pressure and complications of high blood pressure in a pregnancy. So we start them on aspirin at nighttime from around 12 weeks. And that's just because that will decrease the risk of preeclampsia. And the other thing is that a lot of women feel that nausea and vomiting in pregnancy, especially in the first trimester, is unfortunately just a rite of passage that they have to just deal with and put up with. But in women with sickle cell disease, we really don't want them to have too much nausea and vomiting. They're going to get dehydrated. That could potentially trigger a crisis. So we really want to get on top of treating that. Next slide, please. For the second trimester, things settle down a little bit. Second trimester is kind of on cruise control usually, where most women will get a detailed ultrasound, which is kind of that head to toe survey of the baby. And that's always an exciting time. Some women can choose to find out the sex of the baby at that time. Women will also get their gestational diabetes screen, which is around 24 to 28 weeks. Not an exciting test to have, even if you have a sweet tooth, because it's a very sugary drink. So that's for all pregnant women. For women with sickle cell disease, though, you can expect, again, having that monthly urine culture, but also usually our hematologists here will send you for blood count every 2 weeks. And that's because they really want to follow closely to make sure that your blood count is not dropping, to make sure that you're not meeting those thresholds that we require for transfusion. The other thing is that we know that babies of moms with any medical condition, especially sickle cell, can get growth restricted. So that's why we do ultrasounds about every 4 weeks, starting from about 24 to 28 weeks, just to keep a close eye on baby, on the amniotic fluid, make sure that baby is growing and thriving well. Next slide, please. So the third trimester is kind of where we start to rev up and get ready for delivery. So again, in kind of your average low risk pregnancy, maybe we do an extra ultrasound, but again, with the sickle cell pregnant patient, we would do an ultrasound every 4 weeks. We usually do a swab for group B strep, just to it's a bacteria that lives in the vagina, and if it's there, we just treat with antibiotics at the time of delivery. So that's routine care. But if you're a woman who's living with sickle cell anemia, then a couple other appointments we'd have in store, and that is that we want to make sure that that they meet with anesthesia, because even if a woman is not planning to have an epidural in labor, it's still important that an anesthesiologist has a chance to go through their chart when they're not in labor, it's not an emergency, knows their history, in case we need to do a C-section or anything, they have a plan in place. Women also can be taking narcotics in pregnancy. It's safe to take in pregnancy if they have frequent crisis or flares. But in that case, we can sometimes end up with a little bit of neonatal withdrawal, meaning after the baby's born, it's no longer seeing the narcotics that it was seeing inside the uterus. So it might have a little bit of those withdrawal symptoms. So sometimes I will have my moms that are taking a lot of narcotics, I will have them meet with neonatology in the third trimester, just to make sure that they know what the support for the neonate will look like for that. In that case, we repeat the antibody screen to make sure, again, nobody's developed any new antibodies. And usually we recommend delivery between 39 to 40 weeks. And that's really based on just a desire that we know the longer the pregnancy goes on, the more at risk we are of ending up in a crisis. And we really don't want to have any woman laboring during a crisis. So that's why we kind of deliver by their due date, ideally, so that we don't end up in that situation. We recommend a vaginal delivery if there's no other reason not to have one. It's completely fine. And we follow the blood work really, really closely, because if the hemoglobin is dropping at all, then we may need to give a transfusion if needed, just to top them up. Okay, next slide, please. So again, in terms of labor, we strive as much as possible to have a vaginal delivery. We certainly do not do cesarean sections for sickle cell alone. We would do them for the other reasons that we would do cesarean sections. But we do recommend that babies on the monitor the whole time in labor. We recommend an IV, because again, in labor, women they're sweating a lot, they're working really hard. they're potentially vomiting. If they get dry, that can trigger a crisis. So an IV with some hydration in labor is always advised. If we need to give women extra oxygen in labor, again, to prevent a crisis, then we do that. And we always have their blood type on hand in case we need to do a transfusion. Next slide, please. So in terms of general pregnancy risk, so I talked about this to all of my sickle cell disease patients kind of at the first time that I meet them. Next slide, please. So as we talked about, they are at risk of preeclampsia and high blood pressure, which is why we always recommend starting on aspirin from about 12 weeks of pregnancy. So 2 baby aspirin at nighttime is what we recommend. And it is safe in pregnancy, and it has been helping with women's risk of preeclampsia. They are at risk of, again, having a growth restricted baby. So that's why we follow closely with ultrasounds. They're risk of preterm delivery, and that's again more related to crises and early pregnancy loss as well. Sometimes my sickle cell patients do need to be admitted if they're having crises, or if they're having any pain issues, if they need hydration, or if they need pain medication. They are at risk of requiring that in pregnancy. Next slide, please. So in terms of how we manage a crisis in pregnancy, it's probably similar to how we manage it outside of pregnancy. Well, I will admit I haven't managed a non-pregnant sickle cell crisis in a long time, but it's all very similar, where again, we tell our patients, go to the hospital early, go see your doctor early. At the hospital, we right away start an IV, give lots of fluid, give oxygen. Pain controls or narcotics are okay in pregnancy. The only thing is we just can't give NSAIDs, so things like ibuprofen in pregnancy. And just like in our non-pregnant patients, we make sure that there's no infection that's causing this. So we do urine and blood cultures and chest x-rays. Chest x-rays are totally fine in pregnancy. So we do them if needed to make sure that we're not missing an infection. And then transfusions if needed. And we also usually give moms injectable blood thinners, just because pregnant women are at higher risk of developing a blood clot. And on top of that, if they're having a crisis, they would be at higher risk of that. So that's why we always give them those injectable blood thinners in hospital. Next slide, please. So not every pregnant woman actually needs a blood transfusion if she's got sickle cell disease. And to be honest, it's been probably about a year or so since we've had a woman that's needed regular transfusions in pregnancy. And we, again, based it off of what the UK has published, but mostly these are our criteria. So if the baby's not growing well, then we will transfuse, or if the hemoglobin is less than 60, or if women are having multiple pain crises that's not well managed at home. Those are the situations that we've transfused in pregnancy. But overall, most women might need a transfusion top-up in preparation for delivery, but we really haven't been needing to transfuse a lot of women in pregnancy. Next slide, please. So what to expect after our little bundles have arrived. So next slide. So we encourage women, again, with sickle cell and postpartum, you're at risk of have a blood clot. So we encourage them to walk, ambulate as much as possible, stay hydrated. Breastfeeding is totally okay and encouraged. We give them a transfusion if needed. And then we'll usually, as I said, give them that injectable blood thinner, at least in hospital. And even if they go home, they might need to go home with it for a couple of days if they've had a really complicated delivery. Next slide, please. So I think that's all that I have in terms of pregnancy. I'm happy to answer as many questions about pregnancy and maybe even leading up to pregnancy if there are any.
Thank you so much, Dr. Soliman. This was a very good presentation. So I have a couple of questions, so I'm going just to, go at random. I'm going to start with Teonna first, and then I'll come back to you, okay, Dr. Soliman. So Teonna, the first question that somebody asked here was about men, because you mentioned it, I think, when you were talking. So it says, what's your experience with young men who are also thinking of, infertility issues as a result of sickle cell medication, and how does your organization plans to reach out to them as well? Do you have a plan for that? Or?
Yeah, well, that's a really good question. I have several guys that I've spoken to who are on hydroxyurea, and they were placed on it as children. It wasn't even really their decision. And now that they're older, that's when they're starting to be concerned about if they're sterile or not. And then I've spoken to some who were offered hydroxyurea later in life and refused to get on it because they were, scared of the potential implications. And as far as what my organization plans to do, I don't remember if I mentioned this in the presentation, but I'm also very proud. We have a warrior and caregiver steering committee. So I have guys who are very vocal and transparent about their experience. They will be leading support groups, and they will also be conducting surveys and focus groups for me, just trying to assess the need. And really, that's where my value of engagement comes in, because my co-founders know the data gaps, and I know some of the experiences that women face, but I don't know about the guys. So I will be really leaning on the community and the guys to tell me what they need and how we can better support them. But we definitely have a big plan for outreach.
Thank you. That's great, because usually, they don't talk about it, they will just keep quiet. So I'm glad that you are thinking about bringing it up. So now the next question is going to be for Dr. Soliman. Somebody says that I have two daughters, in the early 20s, and they are listening to this talk, obviously. So what advice do you have for single ladies or men looking for the future and hoping to start families? And it's good because I would like for you to focus on those who have sickle cell disease. If you were to talk to them before they get pregnant, which kind of advice you would give them with the sickle cell traits too, obviously, and of course, anybody else who is trying to get pregnant, what would be your advice to them if you were to talk to them?
So I guess my biggest piece of advice would be to stay on top of managing your symptoms, stay on top of the surveillance, stay on top of following up with your doctor, making sure eyes, heart, liver, kidney, all of that is healthy. And if there is a treatment being proposed that can affect fertility, especially here in Canada, you can have a consult with a fertility specialist who will happily sort of talk you through it. The consults are covered by Alberta Healthcare. It's unfortunately the treatment and the ovarian preservation is not, but at least having a talk to review your medications and what proposed therapy by a fertility specialist will at least hopefully put some people's minds at ease of what they're doing is okay for future pregnancy planning. But definitely the best thing you can do for pregnancy is to keep yourself healthy in the years leading up to the pregnancy.
Thank you. Thank you, Dr. Soliman. Something important that I would like to say is that until I came to Canada, because as I said at the beginning, I came from Africa. Until I came to Canada and I was in America first. Until I went to America before coming to Canada, at the time, I had never met somebody with sickle cell who had had a child in their life. You know why? Really? Because they were dying at a young age.
Yeah.
Because they were dying at a young age. And now people are living longer, because of, what we have available. And here, of course, in, North America, there is a better care. So this is when these kind of issues are arising now, that it's important for us to educate ourselves. So now, again, Dr. Soliman, I'm thinking about those with sickle cell disease, those with sickle cell trait, are growing up and wanting a family. It's good if we reach out to them, during puberty and let them know, because what they should do, what they can, even for the treatment, they're receiving, they should be aware of it. We had a session on Mother's Day, and a mom was saying that the most painful experience that she had, she was so happy to have a child, but the fact that she was taking the painkillers, those drugs. When her baby was born, she had to, to be taken away and go through the withdrawal. So actually, she was born an addict to those medications. So she had to go through this process. She said it was painful to watch. So all this, if we, can find a way to educate them, to prepare them, it's important, right?
Yeah, and that's where we talk early on in pregnancy and say, you know what, it is okay to take narcotics if needed. It's okay to take pain medication if needed. That is something that, our neonatal doctors can help baby. It's temporary and it's supportive care for baby, but we always encourage women to take what they need in the pregnancy to get through.
Yeah, good. So it's good to know that, at least once you are, if the mom can be told, don't worry, because the guilt and the distress that she went through after just giving birth was too much because she had no information. She didn't know, right? So that's why. Okay, the next question says, for you again, Dr. Soliman, how common is I've never heard this word.
Antiphospholipid. Yeah, I see it. I see it in the chat. Yeah.
Yes.
So yeah, it was just so antiphospholipid disease or syndrome is a syndrome that increases the chance of forming blood clots. So you develop antibodies that can cause blood clots. So in a non-pregnant woman or in a non-pregnant patient, it can be in their legs or strokes. That's how it can manifest. In a pregnancy, though, it can manifest as preeclampsia or fetal growth restriction and pregnancy loss. The two are not commonly seen together, fortunately, because sickle cell disease is genetic and antiphospholipid antibody syndrome or disease is more autoimmune, meaning it's antibodies formed by your immune cells. And there's a bit of a genetic predisposition, but it doesn't have the same genetic background as sickle cell disease. So I don't see them often going together, which is good because the two together would very much increase a woman's risk of miscarriage and pregnancy complications like preeclampsia and growth restriction. For a woman who has antiphospholipid antibody disease or syndrome, we always put them on injectable blood thinners through their whole pregnancy and the 6 weeks postpartum, and they're on aspirin, and they're followed very closely because of their risk of clot formation. And our hematologists would also be quite closely involved in their care as well.
Okay, so sorry, it was me who put the question up, and the reason I asked is my sister.
Okay.
And so she did lose her first child, but it took them so long to figure out that she had the antiphospholipid, and she did have a large clot in her leg.
Yes.
And so she lost the baby at 4 months, I think it was. She has since had 2 children, has had IVF to have one, and the other one natural. But the thing is, she's sickle cell trait, and she told every doctor, and all of them were like, that shouldn't impact you in any way. She told, and she's in Calgary.
Yeah, sickle cell trait on its own, they tend to do better. Sickle cell trait on its own, I think probably for her what probably was the bigger culprit of her complications was probably the antiphospholipid antibody, because it does carry on its own a high risk of complications, even without any other underlying disorders.
Okay, thank you.
This is when I'm going to say Dr. Jean Warren, favorite word in this is research, research, research. We need evidence-based data. We need evidence-based data, to make sure that either you have sickle cell trait, you have sickle cell SC, that we know if you want to conceive, if you are having issues, what, so that we can have the information. So somebody is asking about hydroxyurea. I know that, it's the physician always say that if you plan to get pregnant, you stop first and then, till you get pregnant. But somebody put the question, so I'm going to put it forward for you, Dr. Soliman.
We don't recommend it in pregnancy. I'm
sorry.
Yeah.
It's interesting to me that this question came up. I don't know if you guys have the trials over in Canada, but here there's a trial where they have been putting mothers back on hydroxyurea in the 3rd trimester. I just think that historically, with all we've heard about it not being safe, I don't really think that that's something that the community is going to be willing to do. But I know that there's some research that in the 3rd trimester, it may not be harmful.
Wow. Yeah, and that's because in the 1st trimester is really when all the parts are kind of formed, the heart, the brain, all the main parts. So the risk of birth defects really goes down after that point. Really, after the 1st trimester, it's mostly the brain, the eyes, the genitalia that's really developing. So yes, there is some data about putting it for women who really need it in the 3rd trimester. In general, I will say though that women who are pregnant are really hesitant to take medication, as is evidenced when we talked about COVID vaccines in pregnancy. Really hesitant to take anything new in pregnancy, especially a drug that they've been told for years and years do not take in pregnancy. So it would have to be a woman who really needs it.
Yeah, I have a couple questions. I was curious, like I know just speaking in my own personal case, like I have a history of like 4 pulmonary embolisms, failing multiple blood thinners, and also like heavy bleeding, and I just been through a lot. So my hematologist and even my endocrinologist, they were kind of saying that if by some miracle I could afford the IVF, they don't even recommend pregnancy for me. They don't think it's safe. And I hear this from women with sickle cell all the time who are like, their doctors just advise them against it. So I was wondering, in that pre-pregnancy stage, like, are there different scenarios where you just will tell a patient, like, look, I don't think it's safe?
Yeah, and it all depends if their heart function is really compromised, like if they've got what's called cardiomyopathy, where their function is quite a bit reduced. Yes, we may not recommend pregnancy for that because the risk of further decline in their cardiac function with the pregnancy is significant. In women who have really poor kidney or liver function, to a point where pregnancy might actually risk them losing the residual kidney function, we may actually advise against it, or be very guarded. So there are some cases where it's not often that we will say don't even go down this path, but we will say it if we feel that a pregnancy might tip them over, lose a little bit of organ function, risk maternal life.
And then I was doing some research and I came across something that said there's a correlation between low AMH and miscarriage. Can you speak to that a little bit? I don't understand.
Like anti-Müllerian hormone and miscarriage. So truth be told, we don't do a lot of that survey. We don't do a lot of surveillance for that in Canada. So we don't regularly test for it. It's one of those that it's a correlation in studies, but not how clinically relevant doesn't pan out, especially when we have women who have miscarriage as it is, there's 33% of all pregnancies ending in miscarriage, unfortunately. And then when you throw in the complicating factors of a woman who has other risk factors for miscarriage, it's hard to really tease out how clinically significant is that. Yeah.
So something to consider in all this discussion now. With sickle cell disease, we know that now they're starting hydroxyurea has like at an age, very early in their life. And with the risk that we know, Dr. Soliman, there is nothing you can do, because when the child comes to you, when the young adult comes to you and tells you, I've been taking hydroxyurea for 18 years already, how do we preserve, like even if Teonna put on some grains right there, how can we help? What can we do, because we need to keep them safe and alive with these drugs. But
Exactly. And that's where, from early on, it might be worth having a discussion about ovarian or sperm preservation. 10 years ago, ovarian preservation was really experimental. I'd say it was about 10 years ago that it really started being offered even in Calgary regularly. So it's definitely for people on long-standing hydroxyurea, and obviously these discussions are not had with a young child or a teenager, but it is worthwhile as a young adult to test ovarian function and have them see an endocrinologist or a fertility specialist. Yeah.
Thank you. So it's 5 o'clock, Bernice. I'm going to respect the time. I know that this discussion is so interesting. Can we? But we don't want to take too much time of our guests, of course. So I will hand it back to you. The decision is yours.
Okay. So Dr. Soliman and Teonna, do you have time to answer a few more questions?
Yeah, I'm good to go if there's any more for me.
Okay. I think there are 2 more in the queue at least.
Another one.
Okay, if you have another one too, yeah.
Just kind of addressing it, this one about, the egg preservation, and the ovarian of egg preservation. So I think that's the question, because we have to talk about, the context of sickle cell. How to do it, when is the best time, and if they're starting before the age of 5 to give hydroxyurea, what can we do? We need to educate the community, about it, so that the parents, they know that, you're being offered something. And what is even concerning is that now these drugs are all going to developing countries at this time, where the parent might not be that educated. What they want their child to stay healthy and alive. So if we don't talk about the future and all this, and tell them all the side effects, how are they going to be able to make,
informed decision?
Yes, informed decisions. So, and again, I think this was such a great topic and very interesting, and we're so happy that, you were able both to come here and talk about it. The other question, is talking about, avascular necrosis, but not really pregnancies. That's why, we left it there. I think we're going to have the opportunity in some other session to talk about it.
I'll share just briefly, because I guess it came up because I talked about my bilateral hip replacements. So the thing about me is that I was in my senior year of high school. Yeah, so it was really important to me to go to prom and everything. So I was having a lot of pain and I was kind of ignoring it. And then when it just got excruciating, I was told by an oncologist that I was just having a long-term pain crisis. And I was like, I've been in pain for 6 months. And then come to find out it was avascular necrosis in my knees and hips. So it was very, very late stages, and that's why I had to get replacements. But I have it in all my other joints, and I haven't had to have them replaced because I do physical therapy, and there's some medications that you can take so that you don't have to do the replacements.
Okay, so there is a way to just, it depends. That's going to be, a personal decision, you and your physician, right? To decide if you go for surgery or not. Every case is different, as I said.
Yeah.
Well, so I think we come to an end to this discussion. Thank you both. And we really appreciate you being here today. And I will hand it back to you, Bernice, to close the day.
Okay, so thank you everybody for joining us today. Thank you to our guest speakers, Teonna and Dr. Soliman. Thanks everybody for joining us. This was a really great discussion. It definitely is a topic that we don't discuss, which is quite unfortunate when you consider reproductive health and pregnancy, it impacts everybody. So it is odd that we don't actually discuss it as a community. But thank you to everyone who has joined us. It's been a great AGM, and next year I'll be on the other side. So anyway, take care. Have a great weekend, everybody.